My dear friends and colleagues, my greetings to you all. At the outset, I would like to thank the organizers for the wonderful opportunity being a part of the CME program. Now the topic is respiratory harmony, anesthesia symphony, the impact of general anesthesia on respiratory system. The harmony means everything is fine and pleasant. Symphony means it's a well-orchestrated music. Anesthesia in a healthy respiratory system is a very pleasant experience, like listening to a music. Now, before going to the subject proper, let us not forget one thing. We have to remember that the respiratory system is a well-protected domain. We deliberately trespass and intrude into the system for a well-defined purpose, that is administration of anesthesia. But certainly, trespassers and intruders may confront problems at any time. And so also we come across problems occasionally. And the respiratory system and anesthesia. This is the only system, internal organ, which is very open to the atmosphere day in and day out. But it is well protected by the larynx and its reflexes. Numerous other reflexes also protect it, and it is preventing the entry of any foreign matter into it. But we purposely depress the reflexes or abolish the reflexes so that we are able to keep a big foreign body, our endotracheal tube, in the larynx. And we are able to deliver anesthetic agents into the alveoli. Now for anesthesia, we always expect everything to be healthy in respiratory system. The thoracic cage, the respiratory muscles, and the entire respiratory apparatus, the airway, larynx, the tracheobronchial tree, starting from the trachea till the terminal bronchioles, the alveoli, and the alveolar capillary membrane. The alveolar capillary membrane is the most vital structure in the respiratory system, but we must not think that the other parts of the respiratory system are unimportant. This is most vital because here only the gaseous exchange takes place, and all other parts have their own part to play, and everything is vital. And there is a big question. Do we get all our patients presented for anesthesia or coming with a perfect respiratory system? The answer is a big no. Because 90% of the patients come with some respiratory illness. It may be a small respiratory, trivial respiratory infection or a matter of major concern. Now, coming to the functions of the respiratory system, the primary function, as the name implies, is respiration. It is the inspiration of air into the alveoli and the diffusion of oxygen from the alveoli into the blood, and the diffusion of carbon dioxide from the blood to the alveoli, and exhaling the carbon dioxide to the atmosphere. These are the four important functions of the respiratory system we are concerned now. But there is one another most important function, that is phonation. That is a complex process. There are other metabolic functions like acid-basic balance and the trapping of pathogens in the mucus, and macrophagic activity is a very vital thing, which is taking the removal of the pathogens and the particles inhaled in the respiratory tract. And the processing of hormones like angiotensin also is a part of the system's function. Now coming to the two components of the respiratory system, one is ventilation and perfusion. And this ventilation and perfusion are not uniform throughout the lung. Imagine that this is the lung, this is the apex, this is the base. And now we know that it has been divided into three compartments or three zones. And the upper zone, mid zone, and lower zone. Some people call it as zone 1, zone 2, zone 3. But one thing which we observe here is, in the upper zone, the ventilation is more prominent and the perfusion is very minimal. And the mid zone, the ventilation and perfusion are equal. And the lower zone, the ventilation is minimal and the perfusion is maximal. And the reason for this is the effect of gravitational forces acting on the blood column. The blood settles in the lower zone more, and in the apex, it is the ventilation is wasted. In the lower zone, the perfusion is wasted. But if you look at the partial pressure of oxygen in the artery, it will be 132 millimeters in the upper zone, it is 103 millimeters in the mid zone, and 89 millimeters only in the lower zone because the perfusion is wasted. But all these mixed together here and form the pulmonary vein. And this pulmonary vein, the partial pressure of oxygen is 97 millimeters of mercury, which is quite sufficient for 100% saturation. And here, this is only an X-ray just to show that the upper zone is very translucent, there is no vascular markings, and the mid zone is having very minimal vascular markings, and the lower zone is studded with vascular markings. Now coming to the ventilation and perfusion during anesthesia, the venous admixture, which is normally in a normal individual is 1 to 5%, which increases during anesthesia. Multiple physiological factors played for that, and it is from 1 to 5%, it increases to 7 to 10%. And various surgical positions causes variable degree of increase in the ventilation perfusion mismatch. The supine position, more of perfusion to the dependent part of the lung, and the anterior portion gets less of perfusion, and the ventilation is vice versa. In the lateral position, the more perfusion the dependent lung and the upper lung gets less of perfusion, and the ventilation is vice versa. And because of all these factors and reasons, there must be at least minimum 33% of oxygen in the inspired mixture, and it is considered mandatory. Otherwise, this patient will go for hypoxia. In lung diseases, ventilation perfusion mismatch increases depending upon the type of disease and the degree of the disease. And because of that, 50% or little more than 50% of inspired oxygen mixture is essential for these patients. Now, this is a gas exchange. This is an arbitrary picture. The alveolus and capillary. This is a single alveolus. And there is one, the air comes in and goes out. And the capillary, which is running around the alveolus. And if you see that, this is the point of entry, the point of exit. In the point of entry, the blood is deoxygenated. By the time it comes here, the carbon dioxide diffuses into the alveoli, the oxygen diffuses into the blood, and ultimately when it reaches the point of exit, the oxygen is the blood is fully saturated with oxygen. This is highly arbitrary. It is only a diagrammatic picture, but there is something which is very significantly wrong in this, because the capillary size is very big. It looks as if there is all these RBCs are floating in plasma, very happily traveling through this. It does not happen like that normally. In the reality, it will be only doing like this, and the RBCs deform a little and will be touching the capillary walls and sliding through these capillaries, and that is how it is going. It is said that this sort of a contact with the capillary wall is advantageous for the easy diffusion of gases. That is one thing which is said as an advantage. Now coming to this is not the respiratory unit. The respiratory unit is something different. This is the terminal bronchioles with the muscles, smooth muscles. This is the alveolar duct, which expands into an alveolar sac, on which these alveoli are kept on that. And you can see that small pores are opening, and that is called as alveolar pores, which opens the alveolar sac. And now this is a very beautiful system. And as you know, the alveolar duct, alveolar sac, and the alveoli. Now coming to now we see on one single alveolus and its function. And please remember, there are approximately 240 million alveoli in each lung, and there are approximately 2,500 kilometers of capillaries, micro capillaries are winding around all these the alveoli. And the alveolar capillary membrane is only 0.56 to 2 micron thickness. The total surface area of the alveolar capillary membrane in both lungs together will be around approximately 100 square meters, which is equivalent to a tennis court size. And at any moment of time, if you look at the vascular bed of the lung, 500 ml of blood is there, but it is a low pressure system which can hold a very large volume of blood into that. For example, if I am infusing my patient inadvertently with a large volume of fluid, and the whole blood volume increases and the blood is shifted to the pulmonary circulation, this volume becomes, it is not 500, it may become 1000 or 1500. But beyond a point of time, this fluid will try to seep into the interstitial space of the lung, causing a problem. We will come to that next. Now, this is alveolar capillary membrane. This is a very good picture, not a very good picture. But it can tell the story very well. But there are very bad characters in this picture. I'll try to correct it. But before that, we'll try to know there are 6 layers in the alveolar capillary membrane. And this is the alveolar lumen. This is the capillary lumen. And the first layer is the fluid layer, thin layer of fluid which is lining the alveolus. And that is the surfactant layer. And this is the capillary, it is the alveolar epithelium. The alveolar epithelium is a squamous epithelium. It will not look like this. This is a columnar epithelium, and it will be very thick, and it does not permit. We will correct it in the next picture. But remember that this it will be very flat, and it will be very large in size, and so that the diffusion is very easy. Then the basement membrane, and there is an interstitial layer, interstitial space. It is called an interstitial space. It is a very vital structure in lung. And the next one is the basement membrane, and then there is a capillary endothelium. This capillary endothelium is wrongly drawn. It must be looking like an eye, not hanging down like this. There is a thin layer of plasma and an RBC is there. Interstitial space, I have to tell something very vital, important matter about the interstitial space. The interstitial space is starting from the alveolum and slowly splays into the throughout of the lung, and finally it comes around the alveolus to cover it. And correctly speaking, it is a structural framework for the lung. If this interstitial space is not there, the lung will not have its shape like this. It will lose its shape. It will become a duffy structure, and it will not serve the purpose for which is constructed. So the interstitial space is the very important one, and it contains 3 things. One is collagen fibers, elastic fibers, and another thing is glycosome, glycan. And the glycosaminoglycan is a jelly-like substance which makes this interstitial space very supple. And an interstitial space can hold a very large volume of fluid, and it can expand. It is an expandable structure. And when this fluid seeps from the capillary into the interstitial space, it swells up, and it may become double or even become more than double. Ultimately, the fluid-laden interstitial space offers a very big resistance to the diffusion of gases. So that is called, sometimes we call it as a interstitial pulmonary edema. With that, we'll go to the next slide. Now, this is the correction for this previous thing. This is the alveolus, this is a capillary. You can see that the blue layer is the surfactant layer. The blue ice-like structure are actually the epithelium of the, it will not be columnar, it will be still more flat. It is not correctly drawn anyway, but it is not this way, but it is very flat with a central nucleus, very large flat cells. And these cuboidal cells seen occasionally here are the type 2 cells which secrete the surfactant fluid. And these are the macrophages. The macrophages can be there in this area also, so that it can clear the foreign body, foreign material, particles which enter into the lung. And these are the fibroblasts. These fibroblasts are dangerous because sometimes they occupy very vital structures and cause fibrosis, and then the problems will be more serious. Now, there is a disparity between the RBC and the capillary. Please remember that RBC is always 8 micron size in the diameter, but the capillary size is 7.5 micron. So obviously there is a disparity. I am showing this picture only to show that the RBC will not be flowing like this. It will be touching the walls of the capillaries and going smoothly moving towards the other side. And this is a microscopic picture showing that the RBC is actually touching the walls of the capillary and had changed its shape and moving on. And that is why most of the textbooks describe like this. The RBC, which is 8 micron, slightly deform itself to pass through the capillary, which is 7.5 micron. So please understand that the microcirculation of the lung is not very comfortably done, but it has got an advantage of a better diffusion of gases. Now coming to the hyperinflation in anesthesia, when we are giving intermittent positive pressure ventilation, the changes in the pulmonary capillary has to be identified. And the inflation pressure, which is normally used for any patient, is 12 to 15 centimeters of water, and the tidal volume has to be 6 to 8 milliliter per kg, and this should not be exceeded. If you exceed, possibly the pressure in the alveoli will increase, and ultimately it cause some damages, or there will be a problem in the circulation. And look at this picture. This is an alveolus, which is a hyperinflated alveolus. This is a hypoinflated, underinflated alveolus. And when we hyperinflate the alveolus, what happens is all these vessels, capillaries around, are compressed and it loses its shape and it becomes flat. Ultimately, this the breadth will be 2 to 2.5 microns, and the RBC has a thickness of 2 microns. Ultimately, the RBC can go one by one sliding into that with a lot of difficulty. And this is a microscopic structure. You see that the major axis is not able to show the front. The minor axis can only show, and that too, it is fusing through the capillary. It's a microscopic picture. It's a beautiful picture. Please remember that. And this is an underinflated alveolus, where there again you can see that the RBC's diameter is larger, but the capillary diameter is smaller. So it is turning itself and slowly moving through that. And this is a good picture. And please remember that if you do this, what happens is the resistance to the capillary perfusion increases, and it will be reflecting as a transient pulmonary hypertension. Now coming to the alveolar changes during in diseases. This is a normal alveolus, not normal alveolus. It is the alveolar duct, alveolar sac, and a peripheral alveoli. This is a unit, respiratory unit. And this is normal, healthy one. If you see at this respiratory unit, you are able to see that the alveoli are filled with inflammatory infective exudates, which is filling it. There is absolutely no ventilation inside that. More than that, the alveolar walls are thickened, and it is a damaged structure. And here, this is a collapse. Here, there's a perfusion, there is no ventilation. Here, there is perfusion, the respiratory unit is collapsed. And so this is again, both these things will become a shunt, and ultimately the blood going to this area will not be oxygenated. This is an emphysema, the respiratory unit in an emphysema. You can see that there is a structural damage to the alveolar capillary membrane. Because of that, what happens is the alveolar capillary membranes are reduced in the size. Ultimately, the diffusion of gases are insufficient. More than that, air trapping occurs in that and causing a increase in the closing volume. Ultimately, the patient suffers hypoxia. Now, this is a pathological shunt. The picture shows that this is a normal alveolus, the normal perfusion. So there is a ventilation perfusion or normal. But in this, there is perfusion, but something is blocking the alveolus. It can be fluid, or it can be an exudate, or it can be a collapse of the lung so that there is no air entry. So these are the three things. There is no ventilation, pulmonary edema, lobar pneumonia, or atelectasis. And there is no perfusion. This is one condition where there is ventilation is there is no perfusion, and a thrombus from elsewhere in the body, mostly from the lower limb, is transferred to the pulmonary circulation. It blocks the vessel, pulmonary artery, and it is causing an embolism where there is no blood flow. Ultimately, this oxygenation is deprived. It can be pulmonary embolism, it may be segmental or massive. Now, in anesthesia, we are doing a very important thing. We are using the large surface area of alveolar capillary membrane for transferring the anesthetic agents to the blood. It is absolutely fine that way, but in this process, we must always ensure that the vital gas exchange must be uncompromised. If there is any compromise, it will be definitely causing a serious impact on the patient's life. And in the lung diseases, what we have to do is, we have to analyze the pathology and spot the problems and take appropriate steps to address the problem in a scientific way. That is how we can do it in a better way. And the most grave problem in any pulmonary disease, the difficulty in the gas exchange. That is the only thing which is threatening us, literally. Now, coming to the driving force for the diffusion, the pressure gradient is the driving force. As far as alveolus oxygen is concerned, in the alveolus, the partial pressure is 103 millimeters, and the pulmonary artery it is 40 millimeters, and the gradient is 63 millimeters of mercury, which is quite sufficient. Carbon dioxide, the pulmonary artery has 47 millimeters of mercury, alveolus has 40 millimeters of mercury, and the gradient is 7 millimeters of mercury, which is quite sufficient for this diffusion. The reason is carbon dioxide is more than 20 times diffusible than oxygen. So we know that is the thing. This is a very interesting slide. Not very attractive, but it gives a lot of information. The transit time of blood and oxygen diffusion. The flow through the pulmonary capillary is described here. Imagine that this is an alveolus. The mean alveolar oxygen partial pressure is 103 millimeters of mercury. And you can see that a small tiny capillary is passing through the side of it. It is the route of this is the site of entry, site of exit. And this is an alveolar capillary membrane where it is the diffusion is happening. And the total transit time, if the heart rate is something around 70, the total transit time taken for the capillaries to the blood to pass through the capillary is 0.75 seconds. And please remember, this is a very vital thing. And when the blood enters the capillary, the partial pressure of oxygen is 40, but within the 1/3 of the time, less than 0.25 seconds, the partial pressure builds up to 90 millimeters of mercury, where it is sufficient for oxygen saturation to 95%, a little more than that. And the remaining 0.5 seconds is used for slowly building up the pressure and acquiring the equilibrium with the alveolar partial pressure. And there is a question, why should there be an extra time available for this? And the 0.5 second is available as an extra time. And this 0.5 second is a reserved time, and it is to compensate two situations. One is tachycardia. When there is a heart rate increases to double, the transit time may be shortened to 0.38 seconds, and still the full oxygenation to 30 millimeters of mercury is possible, and there's a little more time is available. Absolutely, there is nothing to bother about that. And there is a delay in diffusion. Imagine that this alveolar capillary membrane is diseased and the diffusion does not take very proper easily. It is not rapidly happening. It takes a slow time to reach the 90 millimeters of mercury. It takes 0.5 seconds instead of 0.25 seconds. Even then, there is no problem. There is a little time available as an extra time. Now coming to the all that we have seen in the previous slide, I am condensing here. The heart rate is around 70. The blood travels through the pulmonary capillaries by 0.75 seconds. In healthy alveolar capillary membrane, rapid diffusion of oxygen occurs in 0.25 seconds, the 1/3 of the time, and it reaches 90 millimeters of mercury, where the saturation is more than 95%. On the remaining 0.5 second is the partial pressure reaches equilibrium of the alveoli 103 millimeters. And this 0.5 second is the reserved time to compensate two situations. One is tachycardia of any reason and the delay in diffusion due to any reason. Now, tachycardia during anesthesia. The anesthesia increases ventilation, perfusion, maldistribution. If you think that there is an unhealthy lung, there is a disharmony, particularly when the alveolar capillary membrane is not functioning well, the diffusion takes a longer time. Take, for example, it takes 0.5 seconds to reach 90 millimeters of mercury instead of 0.25 seconds in a normal individual. So there is a necessity for 0.5 seconds minimum. And tachycardia reduces the transit time of blood. Suppose I am doubling the heart rate to 140, the transit time is reduced to 0.38 seconds. Now imagine that this patient develops a tachycardia to 140 and the time is reduced to 3.38 seconds. The requirement is to reach 90 millimeters of mercury is 0.5 seconds, but we are giving only 0.38 seconds. Definitely, positively, there is inadequate diffusion of oxygen and oxygen saturation drops and this patient suffers hypoxia. Now we'll leave this scenario here. We'll try to fix this scenario in another situation. When we are dealing with a heart disease patient, ischemic heart disease patient, the tachycardia reduces the diastolic time. We are reducing the ischemic heart disease means there is low perfusion to the coronaries. And we are now reducing the time available as half. So necessarily reduced perfusion to the coronary will be further reduced to half and the ischemia is aggravated, one thing. Secondly, in this scenario, now the blood is poorly oxygenated and the patient is in hypoxia. So further reduction of oxygen perfusion to the coronaries, that with the hypoxic blood, ultimately 99.9% this patient will go for a catastrophe, which we cannot stop. Now coming to the anesthesia, ideal heart rate for anesthesia is 70 to 90 millimeters of mercury. 70 to 90 per minute. And if you ask me, I always prefer to have a heart rate something around 80 and 85. And when you are using general anesthesia, if it is a poorly balanced anesthesia, the surgical reflexes will definitely be induced, and that induces sympathetic stimulation, and that causes tachycardia. So necessarily, this is it's not an advantageous situation. So we have to identify the cause for the tachycardia and treat it. And most of the time, what is required is a little amount of supplementation of analgesic, or a little amount of supplementation of relaxant, or a little amount of both of these things together, as the case may be, as the requirement is there. And remember, empirical use of beta blockers is very hazardous. And I have seen very many times my youngsters giving anesthesia. And when you say, look at the monitor says the pulse rate is 110 or 105. And then I ask him, why there is a high pulse rate and why don't you reduce the heart rate? And the answer comes from him is that everything is fine, sir. There is no problem. And I tell him, everything is fine for you, but not for the patient. Please try to reduce the heart rate. And the instant response from him is that he will immediately order the technician to get an infusion of esmolol for reducing the heart rate. My dear friends, look at this point and please remember, when there is a tachycardia, there is a reason for that. Treat the cause for correcting the tachycardia. Don't try to treat the tachycardia by giving esmolol. This will also end up in a catastrophic status and it is very dangerous. So try to avoid that wherever possible. And very rarely, a tachycardia with hypertension will be caused by exhausted soda lime, and which we can never miss because it will be a very unhealthy bleeding in the site of surgery, which will never be able to miss that. So it is a very rare cause, but anyway, I am telling that for the sake of completion. Now coming to the absorption, there is one another important thing which almost everybody forgets or neglects. That is called as absorption atelectasis, the post-anesthetic alveolar collapse. This is a result of a study in animal study where the alveoli are filled with different gases and the time taken for 80% of gases being absorbed into the bloodstream it was calculated. And I have taken only 3 gases here. And oxygen takes 1 minute and 20 seconds. Air takes 9 minutes and 21 seconds. Nitrogen takes 12 minutes and 6 seconds. So if we keep this in mind, we'll now go to the clinical scenario. On conclusion of anesthesia, the alveolus has no nitrogen. So the alveoli nitrogen would have been washed off by this time. So it is in a denitrogenized state. And more than that, we cut off nitrous oxide. So what happens is the nitrous oxide which is there in the tissues will be rapidly diffusing into the bloodstream, and from the bloodstream it comes to the alveolus. There is a severe efflux of nitrous oxide into the alveoli, and that is called the diffusion hypoxia or Fink's phenomenon. And this diffusion hypoxia will be dangerous. The patient will be having only nitrous oxide in the alveoli, which is dangerous. So for preventing that, we always do one thing. We allow the patient to breathe 10% oxygen for just 3 minutes and it corrects it. But remember that there is no splinting gas. The splinting gas is nitrogen. And this alveoli, suppose you extubate this patient at this time, there will be a major problem. The oxygen from the alveoli gets absorbed in 2 minutes time as the experiment shows. It will be absorbed totally in 2 minutes time. And ultimately, all the alveoli will collapse. There will be a widespread alveolar collapse and hypoxia, which will be very difficult to treat. And it is very difficult to open up these alveoli because it is a widespread alveolar collapse. And to prevent that, we have to use one technique, that is breathing the room air for 3 more minutes before extubation, so that the lung will be adequately filled with the splinting gas nitrogen, so that the alveolar collapse can be prevented. Okay, now coming to the common lung diseases. The COPD, we all know that chronic bronchitis and emphysema. Chronic bronchitis is a chronic inflammatory disease, and which causes further damage to the respiratory tract completely. But emphysema is a typical damage to the respiratory unit, where there is a damage to the alveolar capillary membrane and alveolar walls and air trapping, and all that we have seen already. And allergic and inflammatory diseases, asthma and other bronchospastic diseases, and infection, pneumonia and tuberculosis. Tuberculosis is a chronic infection, but pneumonia, as we have seen, there will be an exudate filling the alveoli, so that there will be no ventilation in the alveoli. And interstitial lung disease, this is something very, very important. The interstitial lung disease, as I have already described, the interstitial space contains 3 things: collagen fibers, the elastic fibers, and the glucosamine glycan. Now, in this interstitial lung disease, these things will be removed, and there will be scarring, which will be replaced by fibrosis. Please remember, fibrous structures never allow diffusion of gases, so these alveoli will not have a diffusion at all. These patients, it's a chronic disease. These patients go in for chronic hypoxic state, which is progressive in nature. There is no way of treating these patients by the available means of support. And then interstitial edema, I have described the seepage of fluid from the capillaries into the interstitial space will expand it. The water-laden and the fluid-laden interstitial space offers resistance to the diffusion, and this is called as an interstitial edema, which is a precursor for the pulmonary edema. We'll be able to see the seepage of fluid in the alveolus and causing frothy sputum. And the interstitial edema, the patient, if he is a conscious patient, he will only notice that the patient will have cough and difficulty in the saturation. The cough is because there will be say diffusion difficulty, and more than that, compression on the alveolus and the terminal bronchiole. Now, pulmonary embolism we have discussed. It is a transfer of thrombus from the lower limb into the pulmonary circulation, blocking any of the pulmonary branches, arteries. And the lung neoplasm is for completion sake. Now coming to the lung pathology in COVID, there is no discussion of respiratory system is there without the discussion about the COVID in the recent years. It is only a diffuse alveolar damage. The description of the damages are like this. It is an endothelial damage. Literally, there will be capillaritis, endothelialitis, then microthrombosis because of these damages, and the extensive T cell infiltration. There will be angiogenesis, new vessel formations in the whole of the lung, and these changes are widespread, and because of that, there is a gross destruction with diffusion difficulties and hypoxia. Patient suffers very serious damage. Now, carry home message. And my dear friends, so much of discussions, and I find that there are a few points I would want to emphasize. Harmonious respiratory system is a myth. It is not a reality. Very rarely we come across that. If you come across a disease in the pulmonary system, comprehend the pathology first and try to treat it scientifically and optimize the situations and analyze impact on the gas exchange and take measures to improve the gas exchange if there is a possibility, and avoid tachycardia and hyperinflation of the lung, and avoid agents that can worsen the condition which is already there's a damage. And if anybody says that I don't want 8 points to carry home message, dear friends, I can tell you only one single point. Avoid tachycardia and hypertension during anesthesia. You will be very harmonious and your patient will be harmonious and everything will be harmonious. Thank you very much for the patient listening. I thank the organizers once again for giving me this wonderful opportunity for taking part in the CME program. And I have one another person to thank very much. That is Mr. Peter of the Peter Audiovisual System Madurai, who has helped me so much in preparing this preparation for presentation. Thank you all very much. Thank you.